You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is June 3rd, 2024. Our topic today is Abbas Chapter 21, Congenital Immunodeficiencies Part 2, presented by Dr. Nikita Raje. She's an Associate Professor of Internal Medicine and Pediatrics and is the Chief in the Section of Allergy Immunology at Children's Mercy Hospital.
We talked about innate immunodeficiencies last time, so we are on chapter 21 from Abbas, and we are going to be focusing on congenital immunodeficiencies. Acquired immunodeficiencies is for your self-reading. And let's get started. I'm Nikita Raje from Children's Mercy, Kansas City, UMKC. Today is June 3rd, 2024, and we'll continue with our discussion. Here are the disclosures, nothing relevant to the talk today. We talked about innate and adaptive immunity and how each one has its own role. Innate immunity provides the second signal, and then the adaptive immunity is more sophisticated with T and B cells providing very specific response, but it does take time to develop. So, correct me if I'm wrong, but we finished our discussion on innate immunodeficiencies last time. So we'll move on and talk about adaptive immunodeficiencies. So we start with defect in T and B cells. If the T cells are not effective, B cells can also be affected, for their function is dependent on the T cells. And so if T cells are non-functional or are absent in quantitatively, you get severe combined immunodeficiencies. And severe combined immunodeficiency, here's a chart that talks about how different defects at different stages of development of T cells can lead to skin. So here are stem cells, and if there is a defect, they develop into common lymphocyte progenitor and then develop into pro T cells or pro B cells, and then here from there on turn into either pre T or pre B cells, and then develop into various subsets of B or T or B cells. So if there is a defect in the development or factors responsible for development of pro T cells, so common gamma chain, IL-7, IL-2 receptor, IL-7 receptor, JAK3, ADA and PNP enzymes, if any of those are defective, your defect is way high up and your T cells are the ones that are going to be definitely be affected. ADA and PNP lead to defect in B and NK cells, not shown here, but all three can be affected. Versus gamma C and JAK3, it's mainly the T cells. B cells are not dependent on these factors, but NK cells can be low as well along with T cells, right? And IL-7 is mainly the T cells will be defective. If the defect is in some of these DNA repair genes or the ones responsible for recombination, B and T cells can both be affected. And then if the defect is in specifically some of the factors that are responsible for downstream maturation of T cells or signaling of T cells, you'll have various types of defects shown here. So let's think about those stages again, right? So thinking about where some of these molecules are expressed in the T cells during what kind of maturation stage. The T cell maturation will be arrested at that stage if there is a defect in that molecule. In general, clinically, SCID can present with severe infections. These infections can be bacterial, viral, fungal, opportunistic infections, protozoal infections. Even the vaccine strain can cause infection, such as measles or chickenpox in patients receiving MMR or varicella vaccines. These patients can present with severe and recurrent rashes, diarrhea, and failure to thrive. Condition is fatal unless it is picked up quickly and treated promptly, which has definitely become better with the newborn screening that's available for TREX. So looking at this chart here, again, we're not going to go through each line here, but it just shows the mechanism of the defect and the types of disorders, T cell deficiencies that can cause SCID. Now, remember, some of these defects can present with manifestations or phenotype that's not as severe as SCID, such as 22q deletion syndrome. Most of these patients will have some thymic activity, but less than 1% can present with congenital athymia. All right, so kind of going over, again, this is the phenotypic classification of SCID from IUIS classification, and it goes over the same defects and kind of classifies based on the phenotype, right? So whether the B cells are present or absent. So that's your first. So when we talk about SCID, that's defined by CD3 lymphopenia as well as low TREX. So T cells are definitely not going to be there. So it's always T minus. But whether there are B cells or absent B cells, you think of various defects based on that. If your B cells are present, you're thinking of all the causes of just T minus or T minus and NK minus SCID defects. For your T minus B plus NK minus defects, you have common gamma chain, and which is X-linked, compared to JAK3, which is autosomal recessive. When we talk about this defect, the CD marker for IL-2 or gamma is CD132. So if you check the expression of CD132, it would be absent in terms of IL-2 or gamma defect, but in JAK3 defect, there will be presence of CD132. It's just a functional or signaling defect, right? So it's autosomal recessive. In terms of other causes of just T minus defects, IL-7 receptor alpha or CD3 delta, epsilon, or zeta chain defects, CD45, also known as PTPRC defect, or these signaling molecules like LAT defect. All of these can cause pure T minus defects. Again, there are some thymic defects such as FOXN1, 22q deletion that just affect the T cells. Here are a few more: PAX1, Coronin 1A, SLP76, IATPKB. All of these can cause just the T cell defect causing SCID. When B cells and T cells are affected together, you're typically thinking of VDJ recombination that's affected. So that's your RAG1, RAG2, or Artemis defects, or some DNA repair gene defects. When there is a DNA repair gene defect, you typically see microcephaly. There is bird-like facies and microcephaly that has been described with some of these gene defects. So you see that bird-like facies with DNA ligase 4 and ceranose defects, or DNA PKC defect will cause just the microcephaly. Also, there is ADA or PNP defect, which is more of an enzymatic issue. So not only will it affect the immune system, but other issue that these patients can present with it, other typical features, including hearing problems, pulmonary alveolar proteinosis, cognitive defects, rib abnormalities. That's with ADA defects. PNP causes neurological issues along with the SCID. Both of these are enzymes that can be measured and checked on to define or diagnose these deficiencies. Reticular dysgenesis caused by AK2 is another cause of SCID, which has the phenotype of T minus, B minus, and K minus. Another new one that has been described in this category is RAC2 defect. So everything here in red or bold black, all of those are things that you would have to memorize. Make sure that you know the phenotype for each one, right? So these are really high yield questions, and kind of making sure that you know what causes T minus, B minus versus just T minus, or all three of them affected. And then the most common form is your T minus and K minus, which is IL-2 or gamma X linked. Just the same information, nothing that I'm going to go over again, but just kind of again reiterating the causes. Most common form, which is T minus and K minus. With the newborn screening coming through, we are finding way more causes or genes that have caused SCID compared to previous to the newborn screening. So here, this last category, T minus, NK plus, sometimes B cells are present, sometimes they are absent, and some of these causes can go in either direction. So going through some of these causes again, ADA is an enzyme that helps with deamination of adenosine and 2-deoxyadenosine to inosine and deoxyadenosine. So if that's affected, if ADA is absent, then it causes accumulation of deoxyadenosine and its precursors. So the pathway goes in an opposite direction, and so the precursors and deoxyadenosine can accumulate. But these can have toxic effects on DNA synthesis, and the rapidly proliferating lymphocytes are the ones that can definitely be affected. But then you'll see these other features because of the effect of ADA, the accumulation of these toxic metabolites on other parts of the body. PNP, as I mentioned, another enzyme, it helps in conversion of inosine to hypoxanthine and guanosine to guanine. So deficiency causes accumulation of deoxyguanosine and deoxyguanosine triphosphate. Again, has toxic effects on lymphocytes. It will cause progressive neurological deterioration. It can also cause hemolytic anemia and SCID, right? So these are enzyme deficiencies. And so sometimes if when the baby is born and if they get blood transfusion, for example, the ADA from the transfusion can delay the manifestations of ADA deficiency. So these are a couple of causes that sometimes can be missed on newborn screening, so something to keep in mind. Reticular dysgenesis caused by AK2 defect leads to absence of lymphocytes as well as granulocytes. So why is IL-2 or gamma defect, why does it lead to SCID? It's a common gamma chain, so it's present in these cytokines 2, 7, 15 along with 4, 9, 21. So 2, 4, 7, 9, 15 and 21, but IL-2, IL-7 are needed for these T cells, IL-15 is needed for NK cells, and so the defect leads to T minus NK minus phenotype. So, the downstream signaling molecule for IL-2 receptor is JAK3, and so that leads to the same phenotype. And then IL-7 or alpha is mainly important for the development and proliferation of T cells, so just the T cells are affected. We have gone through this, so this is just a recapitulation of what this VDJ recombination looks like. There's a SNC that's caused at the hepatomer and the coding junction, and at that point RAG1 and RAG2 cause the cleavage, and then after that cleavage there is a hairpin formation that is the function of Artemis. Once that hairpin is created and opened up, there is processing at those ends, and some of these molecules or enzymes like DNA-PK, DNA ligase 4, all of these along with TDT add some nucleotides and help to repair those junctions and lead to the formation of the final VDJ recombined DNA. If there is a defect in any of these, both T and B cell VDJ recombination is affected, and so there is T minus B minus SCID. Omen syndrome. So that was mostly described with T minus B minus SCID, mainly RAG1, RAG2, and Artemis. But over time, we realized that any gene defect that leads to SCID, if there is a hypomorphic mutation in one of those genes, it can lead to a phenotype called Omen syndrome. So how is this different? In this disease or this phenotype of SCID, patients may have normal or higher number of T cells. However, those T cells belong to the child or the infant itself, but these are autologous abnormal T cells that are oligoclonal. What does that mean? T cells should be polyclonal, which means there should be variety of VDJ recombined TCRs available on these T cells. Instead, because of the abnormality in this one of these, because of one of these variants or in one of this molecule, the T cells are autologous to the baby, but those are oligoclonal T cells. They lead to autoimmunity. They lead to high IgE level, eosinophilia. These patients present with lymphadenopathy and hepatosplenomegaly and autoimmune issues. They present typically with a rash that is all over, that's more like erythroderma rather than eczematous rash. All right. Well, so that's the discussion about SCID. If you have questions, let me know. We can move on from SCID to other combined immunodeficiencies. And again, these are things that you want to make sure you kind of keep in mind. We talked about this again, coming back to iOS phenotypical classification. This is table B, part of the combined immunodeficiencies, where we talk about just low CD4 cells, just low CD8 cells, or low B cells, along with the combined immunodeficiency. So things to kind of keep in mind: MHC class 2 defect can lead to low CD4 cells. These are patients who present with respiratory and GI infections and liver disease. LCK defect can have similar presentation with low CD4 cells, versus ZAP70 presents with low CD8 cells. As compared to low CD4 cells, MHC, that which is caused by MHC class 2 deficiency, MHC class 1 defects will lead to low CD8 cells. So these are TAP1, TAP2, TAP-BP, compared to class 2 MHC defects, which are caused by C2 or class 2 transcription activator, C2TA defect, and some of these word soups here, RFX5, RFXAP, RF-ZANC. All of those can cause the Bayer lymphocyte syndrome or class 2 MHC deficiency. MHC class 1 deficiency presents a little differently with vasculitis and pyoderma gangrenosum. B2M, so beta-2 microglobulin, which is part of class 1 MHC as well. If that's defective, it can also present with those granulomas and infections. LCK, autoimmune issues. ZAP70 can also have immune dysregulation and autoimmune issues. But each of them will have either CD4 that's low or CD8 that's low. I'll let you read through these other defects here. DOC8 is a big one. It was initially classified as a hyper IgE syndrome. It's no longer in that category. It's moved on to just a combined immunodeficiency because of the defects that we see in B cells and K cells, T cells, and these patients present with a lot of atopy. They also present with recurrent viral infections. That's like the hallmark. So they can have HSV, HPV, other bacterial, fungal infections as well. That's your DOC8 deficiency, Icaros. And so again, these are some of the defects that I'll let you read. We talked about Omen syndrome, that's important. And then some of these other defects like TCR alpha, or ITK deficiency, all of these can present with some of these infections and immune dysregulation as well. Something to keep in mind, this RHO, RHOH, that presents with a lot of HPV infections. Kaposi sarcoma, if you look at that, you think of OX40 as a congenital immunodeficiency, but of course, more commonly it will be present with HIV, which is acquired immunodeficiency. All right, moving along, we are talking about one more set of classification where these are combined immunodeficiency syndromes, which means these are patients who have, apart from immune defects, other systems involved as well. So some of their features can be used to classify them, such as congenital thrombocytopenia. You think about Wiskott-Aldrich syndrome with a triad of eczematous rash, small platelets or thrombocytopenia, and recurrent infections. These are patients who may present a little later than SCID, right? But these patients can have pretty severe infections, and depending on their presentation, you want to follow the classification for Wiskott-Aldrich that tells you whether you should contemplate and consider stem cell transplant in them or not. So patients with just X-linked thrombocytopenia can have a defect in the same gene and may not have infections or rash. So over time, you want to look at where the progression of the disease is. So there are other defects in the same pathway as Wiskott-Aldrich, where there is a defect in this particular WASP gene, and that causes defect of some of the movement of the cells, and so that's X-linked. But we now know that similar defect in Wiskott-Aldrich associated protein or VIP deficiency can present with similar features and is autosomal recessive form. Another one described in the same pathway is ARP-C1b defect, which will also present with thrombocytopenia and infections. Ataxia telangiectasia, we know that can cause patients to have maybe more antibody deficiency, some decreased T cells as well. These patients are at risk for having malignancies. They present with telangiectasias and ataxia, as you know, which may not be present initially. So you have to have higher suspicion to think about this disease. Niemann breakage syndrome is another chromosomal anomaly. Some of these defects here, Bloom syndrome, Niemann breakage syndrome, ataxia telangiectasia, or immunodeficiency with centromeric instability. So ICF1 or ICF2, 3, 4, all of these ICF defects, all of these have DNA repair defects and can have radiosensitivity. MCM4 is a defect with NK cells along with the T cell defect, and they are more prone to having viral infections, and their NK cell numbers are low. Sorry. POL1 defect or Fils syndrome. These patients present again with livedo reticularis and short stature, facial dysmorphism, and recurrent infections. So some of these defects are more of defects with developmental issues as well as facial dysmorphism. Cartilage, so there is another category that has immuno-osseous dysplasia. So apart from immunodeficiency, they will present with bone deformities. So one of them is cartilage hair hypoplasia. These patients can present like skid, and they have short limb dwarfism. And then they have something called telomere shortening. So if you check, and you can check the telomere length, it's a test that you can send through our lab, and they'll test on the telomere length of various cells, which can be short for these patients. Defect is in RMRP gene. Sometimes patients present with SCID, but other patients can present with just a combined immunodeficiency that's less severe. The RMRP gene is actually not a coding gene. So it's not a gene that codes for a protein. It's a non-coding gene. And because of that, it may not be found or detected on the exome testing. Some of the others are skin case disease, and the other one is the Roifman syndrome or MOPD1 deficiency. This is not very new, but a newer defect. And these patients present with lots of infections and some developmental disorders, short stature, and bony issues. So spondyloepiphyseal dysplasia. These patients can present similar to CBID. So we do see some of these patients in our clinic. So something to keep in mind. That table continues into another sub-table, which is table 2B, which is combined immunodeficiency with syndromes. So other category is thymic defects. So we know all these defects, 22q deletion, TBX1 deficiencies. TBX1 is the most important gene or most studied gene in the 22q deletions part. In that, if there is no deletion, but that particular gene is defective or has a variant in that gene, TBX1, then it can present with similar features as the 22q deletion syndrome patients. CHARGE syndrome caused by CHD7 or SEMA3E defects. FOXN1 is a defect in FOXN1 that causes alopecia along with thymic defects. CHARGE syndrome, as the name suggests, it has all those defects. Jacobson syndrome is another one, 11q23 deletion, presents with lots of infections, lymphopenia, and hypogam. These patients have higher monocyte count. 10p deletion is another form of what presents as what we know as DeGeorge phenotype. So similar presentation, but there is no 22q deletion, but the test of choice is microarray, which can detect either 22q or 10p deletions in the same test. Patients with anhydrotic ectodermic dysplasia with immunodeficiency, so ED with ID, these patients can have various defects, the most important one being NEMO defect that has been well studied. These patients can have a high IgA and IgM. So think of, patients can be confused with hyper IgM. So these patients, again, NEMO is X-linked. So X-linked defect with high IgM, high IgA, poor response to vaccines. These patients can have some significant infections like mycobacterial infections, severe bacterial infections, and hydrosis, right? And ectodermal dysplasia. So conical teeth, sparse hair, skin issues, nail issues, you think of this category. Similar to NEMO defect, there is autosomal dominant defect in IKBA, and that can also present with similar features. Another one, EDA-ID, is caused by IKBB. So IKBA, IKBB, and NEMO, so IKBKG. Any of these defects will present with EDA-ID, right? We talk about hyper IgE syndrome. We used to talk about STAT3 and DOC8. Now the DOC8 has moved to another category, but yes, you have to keep that one in mind as well. But now you have this whole list of defects that can present with high IgE. So STAT3 is the typical one we think about. You have your hyper IgE NIH scoring system that you can use clinically to think of whether a defect in STAT3 is likely or not. These patients present with bony issues and the typical coarse features of the facies and recurrent infections, pneumatocoels, pulmonary abscesses, skin infections, and boils caused by staph. They can have fungal infections like aspergillosis, PJP, candidiasis, joint and bone issues, and scoliosis. They have defect in, they may not lose their primary teeth as quickly, so they may have 2 rows of teeth. They have midline defects like coronary or cerebral aneurysms, or can be present as well. So think about that, because that's not a typical thing that you think about with STAT3. These patients will have high IgE, lack of specific antibody deficient production. Sometimes your IgG level will be normal, but these patients can present with lots of infections, and in those patients may still require treatment with infusions. BAFF expression is increased in these patients. Th17 cells are reduced, or function of Th17 is reduced. IL-6 receptor defects can also present with like recurrent infections and abscesses, and they have high circulating IL-6 levels. Similarly, there is defect in IL-6 ST, ZNF 341. Comel-Netherton is caused by SPINK5 defect. These patients have bamboo hair and have, of course, the high IgE. PGM3 can present with neurological issues as well as high IgE and atopy and infections, along with autoimmunity, and they can have neurological issues because of delayed CNS myelination issues. So think of that when you have high IgE and neurological issues. CARD11 is a defect in that leads to atopy and lots of viral infections along with high IgE. Loeys-Dietz syndrome is another one with recurrent infections, atopy, bone issues like scoliosis, retention of primary teeth. So it kind of looks very similar to STAT3 defect. VCL11B defect, urban defect, all of these can have high IgE and similar presentation. Sorry, I don't know why this particular slide moved, but I did point out some of these things already, so we'll move on. Some of the other combined defects that I definitely want to point out is ORI1 and STIM1. So this is a defect in this pathway of NFAT, sorry.
Oh, nothing. Sorry, I was just talking to myself as you're teaching. My bad.
Okay, so the NFAT pathway of signaling in T cells needs that release of calcium, and the calcium, when it's low in the endoplasmic reticulum, it is detected by the sensor STIM1 in the endoplasmic reticulum. Because of it, it causes attachment to the crack channel in the cell membrane and causes release of or influx of calcium into the cytoplasm. This crack channel has a protein named ORI1. So a defect in ORI1 in the crack channel or the STIM1 in the endoplasmic reticulum can lead to defect of T cell activation with myopathies. So think of calcium and myopathies together. The T cell development is fine. It's the signaling that's affected. Here, barrel lymphocyte syndrome we already talked about. We talked about that. We talked about ZAP70 with low CD8 cells. We talked about LCK. UNC119 is another one that causes low CD4 cells. All right, so in that category of syndromes, we talked about 22q deletion. There is defect in third and fourth pharyngeal pouch development. So thymus, parathyroid, heart are affected, cleft lip, cleft palate, and overall the midline features structures are affected. TBX1 is the gene that you should know about, is that's affected in this region, 22q1 1.2 band, and treatment is supportive for most patients. So antibiotics may need infusions. Some patients will have B cell defects. Most of them is just pure T cell. But remember, when T cells are affected, B cell function can be affected. Less than 1% have congenital athymia, where they need thymic transplant. And which, just to kind of point out, thymic transplant or implant is what it's called, cultured tissue, thymic tissue implant. CTTI is now a FDA approved product. FOXN1, we talked about alopecia and thymic aplasia. Nail dystrophy is another feature of that. We talked about the rest. Scott Aldrich, we talked about that. Defect WASP help interacts with this GRAB2 Rho proteins that help in movement of the cells. So actin cytoskeletal rearrangement is affected. And we talked about the rest. Hyper IgM syndrome. Here, the defect is not in T or B cells, but in the molecules that help in communication between the two cells. The cells can be normal in number. IgM is high. Ideally, IgG, A, or E would be absent, but not necessarily so. The typical defect is CD40 ligand or CD40 that causes recurrent bacterial infections, opportunistic infections, and poor response to vaccines. Defect in the B cells with class switching can be present in these enzymes called AID-UNG, and they can also lead to hyper IgM syndrome. Now remember, NEMO is not a hyper IgM syndrome, it just has high IgM. Similarly, PI3 kinase defect can present and can have high IgM, but it's not necessarily part of hyper IgM syndrome. One of the typical infection that you associate with hyper IgM syndrome is Cryptosporidium infection, and then liver can be affected. So think about that. AID and UNG, we talked about this. This is the switch region where the AID comes and converts all the C's to U's, and then the UNG will take away. It makes that site A basic. And then APE comes along and makes NICs at those places, and then there is class switching. If there is a defect in AID and UNG, unlike the CD40 ligand defects, these patients can have lymphoid hyperplasia along with that high IgM. But they will not have opportunistic infections because the defect is pure B cell and the T cells are completely normal, so you don't see opportunistic infections here. Hyper IgM, we talked about some of these, don't need to go over that. This is the typical course features that I was talking about. So kind of keep that in your mind. Rhexia telangiectasia, we talked about that. All right, moving along from those two categories of combined immunodeficiency, this is the other category, immune dysregulation. Here, this first table goes over two sets of disorders. One is familial HLH, and the second one is disorders with EBV susceptibility. So things to keep in mind, familial HLH can be caused by defects in this a transport system or granule system of NK and CTL cells, right? And that causes familial HLH with hypopigmentation and partial albinism. That's your Griscellis syndrome due to RAP27A, Shade-Yakigashi because of defect in LIST, Hermansky-Pudlak. HPS is the only one that causes immunodeficiency is type 2. So Hermansky-Pudlak syndrome type 2 is caused by AP3B1 and I think 2 and 10. I forgot about that. So AP3D1. So these are your familial HLH with hypopigmentation. But then there are defects in other molecules that can cause just familial HLH. That's perforin defect, UNC13D, Syntaxin, STXPP2 or MUNC18-2. All of these can cause familial HLH. SLC747, CDC42 or NOCAR syndrome. Don't remember that name. CDC42, I think it had another name, but I won't even mention it because that doesn't make sense. They changed the name, I think. All right, so all of these, FAAP24, Rogue, all of these can cause higher chance of causing familial HLH or of getting HLH. What is HLH? HLH is high, having a severe and very acute presentation with fever, hepatosplenomegaly, cytopenias, and decreased NK and CTL cytotoxicity, but at that time there is all this inflammation that can be seen. I won't go over the criteria, but there are clinical criteria that you have to meet to meet the diagnosis of HLH for treatment. Sometimes there is CNS HLH, and then sometimes there is partial. Patients may meet partial criteria for HLH that may need treatment as well. EBV, so here is a list of defects that can increase your susceptibility to EBV, and EBV can increase the chances of having HLH. So sometimes these two categories go hand in hand. So important one, so that's actually mentioned here. Okay, so EBV associated HLH is present in XLP1, XLP2, XLP1 caused by SAP deficiency, SAP deficiency caused by defect in gene SH2-DIA, and XIAP defect that presents with early onset IBD. These patients will have lack of invariant NK T cells on your flow cytometry. So this is the condition. If you have patients with early onset IBD, you are looking at flow cytometry. For our institution, we look at our extended immunodeficiency panel rather than just looking at TB and NK markers. CD27 is a marker of memory T cell or memory cells in general, and so defect in CD27. So if there is lack of CD27 expression, you can see increased susceptibility to EBV infection and HLH. But then there are these EBV defects that can present with mainly just EBV, but these are patients who will have EBV proliferation, lymphoproliferation, and susceptibility to lymphomas. So CD7T, ITK, PRKCD, X-Men syndrome. X-Men is caused by MACT defect, MACT1 defect, CARMEL2, CTPS1. All of these are defects that can increase susceptibility to EB1. This is the second table for immune dysregulation category, and that's your defects in defects with autoimmunity. Is there a defect in regulatory T cells? That's another category where we think about IPEX and IPEX-like defects. If there are no regulatory T cell defects, there are a few things to keep in mind. There's ALPS, autoimmune lymphoproliferative syndrome, or there are some conditions like APASED. So few different things. Let's talk about this IPEX. IPEX is caused by FOXP3 defect, immune dysregulation, polyendocrinopathy, enteropathy, which is X-linked. Patients present with lots of diarrhea and early onset diabetes, along with infections. There can be high IgE, there can be high IgA, there is lack and impaired function of FOXP3 Tregs. Sometimes if you check on that FOXP3, CD25, CD4 expression, so expression of Tregs, it may still be present. When you are checking this test, it's just looking at expression, it's not checking for function. So keep that in mind that you may have a normal test result on flow cytometry, but if your suspicion is high, you still have to get your genetic testing. STAT3 can cause gain of function. For the one we talked about with hyper IgE was your loss of function. This is gain of function that presents with autoimmunity. LRBA is another one. CTLA4 and LRBA are the same pathway. Two various two different defects in the same pathway, but they present with cytopenias, enteropathy, lung disease. CTLA can present with neurological issues as well. LRBA presents with a lot of bowel disease and autoimmunity and infections. BAC2 presents with colitis and cyanopulmonary infections as well. CD25, say CD25, it's IL-2 receptor alpha, right? That if that's defective, you present with autoimmunity and lymphoproliferation as well. DEF6, CD122 newly added. CD122 is IL-2R beta defect, so still lymphoproliferation and some autoimmunity that you see. Icaros is something to, again, a significant autoimmunity that you'll see with this disease, along with allergy and lymphoproliferation. Evans syndrome, which is anemia, autoimmune anemia and thrombocytopenia, along with infections. So that's your category of IPEX with autoimmunity and endocrinopathy and rashes and things like that. So if you have FOXP3 defect with those symptoms, then it's IPEX. And there are other defects in this category that are called IPEX-like that we just talked about. Then you have your ALPS, autoimmune lymphoproliferative syndrome. Here there is autoimmunity and lymphoproliferation, as the name suggests. Defect is in FAS or FAS ligand. Remember, these are germline defects that we are talking about, but FAS can also have somatic defects where the defect is only in T cells, and if you just check your blood test, it may come back normal. So here you're looking for autoimmune cytopenias and lymphoproliferation along with elevated double negative T cells. Again, ALPS and ALPS-like syndromes. So ALPS is your FAS and FAS ligand defects. If the defect is in other genes like caspase-10, caspase-8, FAD, all of these are ALPS-like defects. Caspase-8 can present with recurrent infections. Otherwise, these patients will present with a lot of adenopathy that's visible from the door, right? It's that prominent, along with splenomegaly and the autoimmune cytopenias. Testing will show lymphocyte apoptosis defect, high FAS level. In FAS ligand defects, you might see high vitamin B12, high serum FAS ligand, and IL-10 levels. So these are some of the things that we check on, along with triglyceride levels. All right, APOSED is another one. Defect is in AIR gene. AIR gene is the one that makes AIR protein that helps to express antigens from the other organs to the developing T cells in the thymus. If the AIR gene cannot, or AIR protein cannot do that because of a defect, the other organs' antigens are not noted by the developing T cells, so they can be self-reactive. That can cause hypoparathyroidism, hypothyroidism, adrenal insufficiency, diabetes, and other endocrine issues, also known as EPS1. So something to look at with all these defects. They frequently test you on this particular condition. Itch defect, prolidase, SOX1 defect is now, is again something that has been noted with lots of cytopenias, autoimmune cytopenias, autoimmunity, psoriasis, and lymphopenias, another defect in this category. GPP2 is another one. We have one more category to talk about. Immune dysregulation with colitis. So this is your very early onset IBD or early onset IBD, your IL-10 cytokine or receptor defects can lead to early onset IBD. And some of the other ones in this category are L4, RIPK1. L4 is one that presents with inflammatory bowel disease, recurrent fevers, a lot of inflammation, things like that. And FET5, IL-21 are a couple of other ones in this category. So all of these patients can present with colitis. All right, we talked about some of the HLH information. What I wanted to show you was this picture with the granule formation. These are packed in vesicles, and then they are transported in this transportation system along the cell so that they reach the surface. Then in the immunological synapse, they make a hole. Perforin makes a hole in the cell membrane of these two cells so that the granzymes and ceroglycans can act. Granzyme B is the important one, but other granzymes as well. They can be released into the target cell, and that target cell can undergo apoptosis. However, a defect in any of the proteins or any of the molecules that are important for this transportation system can lead to HLH. So the defect can be in RAB27 causing Griscelli syndrome that helps with docking of the vesicles on the cell membrane, AP3, which helps with polarization of these vesicles, and then LIST, which helps with sorting. So all of these have just various functions in this transportation system, and defect in these will cause HLH, with that these three specifically causing hypopigmentation, and then other molecules like MUNC18-2, syntaxin, MUNC13-4, all of these can cause various familial HLH, different types that are named here. Perforin defect is another one. SAP and XIAP defects can cause XLP. That can also increase your susceptibility to HLH. We talked about cardiac Higashi. Cardiac Higashi is a defect in phagosome lysosome fusion. There are giant lysosomes in neutrophils, monocytes, and lymphocytes, and there is partial oculocutaneous albinism, and that's because of pigmentation issues. NK cell function can be abnormal as well, and there can be nerve defects because of lysosomal abnormalities in nervous system, and then bleeding disorders because of defects in platelets. Here's the pigmentation in cardiac Higashi, where there are clumps of the melanin that are formed that lead to that albinism. All right, moving along from the immune dysregulation category to antibody deficiencies. Any questions?
Raje, this is all red. You said for us to know what's in red. Everything on every slide is all in red.
It's all red, and this is just a classification from IUIS, right? And so you really want to know some of these defects, but I think some of these are intuitive. So that's the good part about it. And then some of them are just, they are in red in this table because they are that's how they formatted it. So not necessarily that I made it red, because I make some things in red for you to memorize it. So I'll point out some of the things that you really want to kind of pay attention to. So antibody deficiency is easy. We deal with that clinically a lot. That's one of the more common presentations that you'll see in your clinic. So things to think about: when B cells are absent, we are thinking of AGAM patients. If the B cells are more than 1%, you're thinking of more of a CVID picture. XLA is caused by defect in BTK, right? That's your X-linked, one of the most common form of AGAM patients, but there are autosomal recessive forms. And thinking about that, BTK helps in clearing that signal through the pre-B cell time of development. If the signal goes through BTK, then the pre-B cells get the permission to develop further into mature B cells. So in case BTK signal doesn't go through, as in XLA, then those pre-B cells cannot go forward with their development. So thinking about that pre-B cell stage where this defect occurs, the other molecules that are important in that during that stage of development of B cells, think about the mu heavy chain and the surrogate light chain like lambda phi. The BTK is the X-linked molecule, but the adapter molecule along with that BTK, this is a kinase, in that signaling is your blink. So if there is a defect in blink, or Ig alpha and Ig beta are your signaling molecules in B cells. So defect in any of these molecules, they have these names CD79A and B, but defect in that signaling pathway. All of these are very intuitive because this is the mu heavy chain in that stage, lambda 5, which is the surrogate light chain, the signaling molecules Ig alpha, Ig beta chains, BTK, and blink. Defect in any of these will arrest the development of B cells at that stage. So these are pretty intuitive. Coming back to these molecules, not so much, but you have to at least know these names: TCF3, PIK3R1, PIK3CD. So these are, again, some things that are so important. PIK3CD causing APDS gene, APDS. So, and then we actually have a patient with SLC 39A7. These patients can all present with AGAM. TOP2B is another one that's autosomal dominant. So we were talking about autosomal recessive. Here are some autosomal dominant ones: SPI1 and TCF3. FNIP1, again, that's something that's actually something that I haven't come across. Recurrent sinopulmonary infections, bronchiectasis, and heart defects. So AGAM is absence of B cells and lack of antibodies and functional antibodies. CVID, there are B cells, but they can be low, but they are present. Mature B cells are present, but they may not make enough antibodies. So thinking about CVID, some of the genes would be anything that's a receptor on B cells. So CD19, 20, 21, 81. So B cell receptor, B cell co-receptor, any of these defects can lead to CVID. ICOS, where is ICOS? I don't even see it. TACI is another one that's associated with CVID. BAF is the B cell survival factor. Defect in NF-kappa B1, NFKB1, NFKB2. These are actually some of the common ones. IRF2, BP2. We have patients with these defects that can present with CVID. But again, P10 is another one. APDS1, APDS2, really important to learn these because these are some of the more common ones that we are learning of. And now we have a medication that can be used in these patients, that is FDA approved, lineolizumab. So kind of learning about some of these disorders is important. So moving on and talking about your hyper IgM syndrome, we already did. So AID and UNG, we talked about. A couple of others to think about is INO80 and MSH6 that can also present with high IgM. Other ones that you think about are not genetic: selective IgA deficiency. IgA has to be less than 7. Above 4-year age when we diagnose that. Transient hypogam of infancy, not going into the details of that. Isolated subclass deficiency, not so much of something that we treat or test for. Subclass deficiency with IgA deficiency, you have to at least know that these categories are there, but you don't know the genes behind some of these defects. So kind of just keeping in mind. CARD11, we talked about CARD11 in terms of loss of function. This is gain of function. Here, the B cells are high in number. It causes something called CARD11 gain of function or Benta syndrome. Splenomegaly, lymphadenopathy, and poor response to vaccines. And that there's possibility of malignancy. So just kind of keeping in mind. Here we are talking about very high B cell numbers, not just a reactive elevation. All right, so we talked about these B cells that go to the bone marrow and make these antibodies. And we talked about these various stages of B cell: pro-B cell, pre-B cell, immature, and then mature B cells. So the defect can cause sinopulmonary infections, ear infections, pneumonia, GI infections. And we think about these AGAM patients as not having B cells, immunoglobulins, or vaccine responses. You give them infusions. Their infections start after 3 to 6 months of age when maternal immunoglobulin disappears. We talked about some of these defects. We think about CVID when B cells are present, but no or low immunoglobulins and no functional antibodies. Bacterial infections, autoimmunity, malignancies, granulomas. Some of these disorders, some of these manifestations are non-infectious, so they may need immunosuppression and biologics along with infusions. Here are some of the defects. IgA deficiency, we talked about that. These can evolve into CVID and autoimmunity, and you pretty much monitor them, give them prophylactic antibiotics. If they do not respond or they have subclass deficiency as well as poor response to vaccines, you can consider infusions. Specific antibody deficiency can be part of another immunodeficiency. B cells are normal, immunoglobulin levels are normal, their response to vaccines is low. Transient hypogam, normal B cell numbers, normal response to vaccines, but the immunoglobulin GAM is low. This can appear, this is typically present by around 9 months age, but if it is prolonged up to 2 to 5 years age, you have transient hypogam of infancy. Most of them are asymptomatic, do not need treatment. Some of them may need prophylaxis or treatment. Some of the other categories are autoinflammatory syndrome, which is again going through. I have 15 more slides. I don't know if you have the second talk right now. Before I go on to this category.
I believe we do have board review with Dr. Pandya, but I mean, if you want to continue until she gets on.
Okay. So I might be able to get through this category, but then we'll stop and then continue with this chapter at the end. I think there's just a lot more information added that's actually not new information. So you could be tested on some of this information. In the past, I was able to not talk so much of the details, but I think it's important to go over some of these details as we know more about these conditions. Autoinflammatory disorders, we think about these as your recurrent fever syndromes or periodic fever syndromes. Also, there are some other conditions like interferonopathies and systemic inflammations, which don't have fevers as their manifestation. So, or actually this category is the one with the fevers, but we have another category that doesn't. So we'll talk about that. But here are our recurrent fever syndromes. Think about these as how many days the fever lasts. So for familial Mediterranean, it may be 1 to 2 days, up to 4 days. Mevalonate kinase, which is hyper IgD, more 5 to 7 days. PFAPA has no gene defect. That actually continues for 3 to 5 days. Your CAPS, familial cold autoinflammatory syndrome or CAPS, NLRP3 defect, NLRP12 defect that can last for 1 to 2 days. They have hives, arthritis, they have conjunctivitis and amyloidosis for NLRP3 particularly, can present really early in neonatal life, known as NOMID or SINCA. They have neurological issues with that. Or later in life, Muckle-Wells syndrome, where they have deafness, and then later in life, FCAS, which is more of just arthritis and cold-induced urticaria. All three of them have urticaria, conjunctivitis, amyloidosis, and that can be affected. Hearing can be affected. A20 or TNF-AIP3, these patients can present with like Behçet's syndrome. So lots of mucosal ulcers, mouth ulcers, and fevers and arthralgias. PLAD is because of PLC gamma 2 defect, cold-induced urticaria, hypogam infections. NLRP1, dyskeratosis, autoimmunity, and arthritis. We talked about hyper IgD syndrome, familial Mediterranean fever. These patients can, colchicine is actually approved for familial Mediterranean fever. TRAPS, where the fevers can last for weeks. Hoyle and HOIP deficiency, we actually have a HOIP deficiency patient. These patients can present with lots of infections and autoinflammation. RIPK1 defect can present with lymphadenopathy and prolonged fevers, ulcers, splenohepatomegaly. TBK1, these are again some of the other fever syndromes that you can read about. Interferonopathies are patients who present with progressive encephalopathy. So something to think about if you are called for encephalopathy patients and asked about immunodeficiency, think of this category. One of the couple of important ones I want to point out here So we talked about these encephalopathies that's called Aicardi-Guterres syndrome, but then there is ADA2 defect. These patients can present with early stroke, ischemic stroke, or in early childhood. So that's ADA2. The ADA1 is the one that causes SCID. This is a different kind of ADA, right? STING deficiency or SAVI is STING-associated vasculopathy, lung and skin issues. So think of vasculopathy and inflammation in the lungs, think of SAVI. USP18 causes torch-like syndrome and neurological issues with ATA-D3A, and then STAT2 can cause inflammation as well with fevers. All right, so that's where I'm going to stop. So we have 15 more slides to go over, part of autoinflammatory syndromes that we'll talk about, mainly with bone and joint infections and some other non-specific inflammation here. And then there are a couple of categories. So really we are coming to an end here. So not much left. So we'll be able to complete this. You guys have the slides to go over, but all the best. I will see you guys on June 17 when we'll do our final Jeopardy. Thank you guys.